All right, well, next we're going to talk about medication-facilitated airway management. And this is not a lecture on how to do medication-facilitated airway management, but rather about what it is and to ask the question, should we be doing it? So remember, emergency airway management is all about, first and foremost, oxygenating a patient, second, minimizing the risk of aspiration, and third, getting rid of excess carbon dioxide. In MFAM, we use medications to create optimal conditions for invasive airway management. Now, medication-facilitated airway management is permitted to EMS in every state, just not necessarily permitted to every EMS provider. But this is a customary practice across the United States. The Lifelight experience shows medication-facilitated airway management to be 100% successful. Now, that's not a 100% intubation success rate, but again, remember the goals of airway management. Oxygenation, decreasing the risk of aspiration, getting rid of excess carbon dioxide. 100% of the time, their medication-facilitated airway management program does just that. So, rapid sequence intubation is the quintessential medication-facilitated airway management, although there are other models. And the goals of that are basically to make it easier to intubate, to prevent aspiration, and to blunt the trauma of an awake intubation. The old rodeo intubations where the patient was bucking and fighting, not good for the patient, not good for you. It creates a hyperadrenergic state, there's psychological consequences, and there's physical trauma to intubating that way. Rapid sequence intubation makes it all much better and safer. So these were techniques originally taken from the OR, then to the emergency department, where they were really perfected for these emergency airways. These are not day-to-day OR intubations. Most of those are done under sedation. Patients aren't paralyzed. In rapid sequence intubation, we're taking awake, not necessarily alert, but an awake patient. We're oxygenating that patient, and we're intubating that patient. And one of the most important goals, and often done wrong in emergency department intubations, is that you're doing it without positive pressure ventilation, because you're taking a patient with an unknown or a known and not good NPO status, with a stomach full of something, and as soon as you start ventilating that patient, the risk of them regurgitating or vomiting and aspirating goes through the roof. So ideally, from the time you start to the time you put the tube through the hole, that patient has not received one positive pressure breath. It's been done in the ER with great success, and then the same techniques have been taken to the EMS realm. What we know is that for it to work at all, you need to have good QA and QI, you need to have good oversight, and you need to practice the skills regularly. And when I say practice the skills, that means, just like any medical practice, to actually do both the skills of intubation, but also the skills of the decision-making around rapid sequence intubation. So is it being done? Sure. This is older literature, but even back in '98, there were many states using neuromuscular blocking agents, and the rest intubations were happening with sedation. And can paramedics successfully do it? Well, yes. This study, it's one of the seminal studies in rapid sequence intubation. This was the San Diego head injury trial, so patients with severe head injuries. And in this study, paramedics were able to successfully intubate patients using RSI. It was prospective, almost 85% successful ETT, and then almost all the rest that they couldn't put an endotracheal tube in got a combi tube. There was one failed airway, and even that was not necessarily failed airway management, but there was not an invasive securing of the airway. And there's other evidence that paramedics can do this. So this is from Dr. Wayne's system, very liberal criteria, 20-year review. It was a retrospective study, but close to 1,700 consecutive patients, medical and trauma, who underwent RSI and had a 96% success rate of intubating the patient, and the rest were managed by alternate means. So 100% successful airway management. There were a few esophageal intubations, but look at the date on this, 1999. This was before we were routinely doing continuous waveform capnography. And there's other evidence as well. And then this as well, more recent, 2008, 97% intubation rate, 4 crikes, 2 bag valve mask ventilation. Now, of course, there's always some negative literature. There was no change in intubation success rate or crike rate with the addition of rapid sequence induction and a protocol. And then this, although not an RSI study, is in fact the probably most important study in EMS airway management and, frankly, emergency department airway management in 20 years. And basically, what they found was that a quarter of the endotracheal intubations done in this EMS system were unrecognized esophageal intubations. And ultimately, addition of continuous monitoring end tidal CO2 eliminated that problem. So what do all these studies imply? It's a mixed message. The in-hospital expectation is a greater than 98% success rate. Not necessarily intubation rate, but securing the airway with an invasive intervention. And in Wayne's system, which was a single system with great oversight, liberal criteria, so each provider got lots of intubations, they didn't make that 98%. Now, an OX study, that's the San Diego head injury study, it was 7 separate provider systems with relatively strong oversight and very narrow criteria. And it was a prospective study. And when it was published, this 85% success rate, there was a national expert consensus that this was not a successful RSI program. So in the hospital, we have experienced personnel, we have highly competent and experienced and trained intubators, and perhaps more importantly, they really aren't focusing on intubate. They're focusing on when should I not intubate and manage the airway other ways. And so we know that with successful intubation rates, we can increase the intubation, actual RSI programs will increase the actual intubations. So if we accept all this, paramedics can perform RSI. It improves intubation success rates probably, but it doesn't meet in-hospital standards. And there's actually no great evidence that patients do better, at least not in the San Diego trial. So biggest trial of its type. It's the same data set as before. There was actually an increased mortality rate for field RSI patients. The mortality increased by 1/3. On the other hand, this is a study where the patients were either randomized to EMS or hospital RSI. The EMS RSI success rate was 97%, pretty darn good. And there was a favorable outcome towards the EMS intubation. So that's more recent data. So that's good evidence that people do better in a good RSI system. So what we conclude from all this is that paramedics can do RSI. Successful intubation rates will improve. We may hurt patients with the procedure. Patients may do better from the procedure. And a lot of work is still needed. Now, do you have any guesses why patients may be hurt by field RSI? Well, this is an emergency department intubation. You see one guy getting in a great position to intubate. You see 2 people in the background. What are they looking at? Doctor, the oxygen saturation is 97%. It's 96%. It's 95%. The patient's heart rate is increasing, doctor. So maybe the answer is that in the EMS environment, it's very hard for us to monitor the patient as well as we can in the hospital setting during the intubation. So again, same data set, a lot of publications came out of that study. 57% of the patients had a pulse ox of less than 90%, and on average, they were hypoxic for almost 3 minutes. 11% got hypoxic bradycardia with heart rates less than 50. That can hurt somebody. So how can you make it work? Well, checklists so that everything's ready, optimal first attempts, a team approach, lots of practice, and good QA and QI. So can we do RSI in Maine? Yes, we have a local model. We have LifeLate, which is a very successful model. We have other national models. They use different crew configurations, but we have these models that show that we can successfully do RSI. Any questions? Please email me. Thanks so much.